Hi, I'm Sandy Werner, and thanks for joining us in this month's Ultrasound Journal Club for the fellowships. And it's sponsored by both ACEP and AEUS from SAEM. And I am your host today. So I'm going to just kind of give you the rundown for how the day will go. So we usually start with an author presentation, and we will do that with some Q&A. And then we're going to break up into some small groups, and we have another article to discuss, and hopefully everybody read both articles so we can have some good discussions. And then we'll come back together and kind of each group will kind of give their take home point from the article that we reviewed. And then if anybody needs a methods consult, if you're doing research, interested in doing research, have some questions about what you're doing, please hang around after 3 o'clock and we will get to those. So reminders, mute yourself, but turn on your camera. And then when we're in the small groups, please unmute yourself. If you can, change your screen name so we know if you're a resident, a fellow, faculty, and where you are. I realize you have to go back about 5 steps in Zoom to do that, so don't worry about it. So the first article is Diagnosis of Central Retinal Artery Occlusion in the Emergency Department using POCUS, and it's a case series. And our guest speaker today is Nicholas Cozzi he's actually assistant professor at Rush University. And, somehow he's done all this EMS stuff, and he did a fellowship, and now he's the EMS medical director there. But if you look up Nicholas Cozzi and ultrasound, there's papers published. That's the one that we're going to talk about, one with Mike Gottlieb. So I'm going to let him kind of tell us how he wound up doing ultrasound stuff and then transitioning to EMS, or if it was all together, or what happened. So I'm going to turn it over to Nick, and I'm going to stop sharing.
Thank you very much, Dr. Werner. It's a pleasure to be with you today. Nicholas Cozzi from the south side of the city of Chicago, and I couldn't be more proud to be here with you today. My journey has been from Michigan to Grand Rapids, where I did my residency at Spectrum Health, now Corewell Health, off to the fire department in New York City. And each and every opportunity that I've been provided or been exposed to, ultrasound has been something very essential and very central to my education and training, but also my clinical patient care. And so the opportunities, whether it's with the article we'll discuss or with Dr. Mike Gottlieb, one of my colleagues here at Rush, with endotracheal intubation and confirmation with ultrasound, all of those opportunities have really been part and parcel, being curious, being inquisitive, and being very much a team player and being collaborative. All the skills that I know that the fellows here in the audience today are cultivating or have cultivated, and will allow them to be successful at the next stage of their careers. So I'm going to go ahead and share my screen. Can you give me a confirmation that you can see my screen? Excellent, thank you. So we're going to discuss an article that I co-wrote with many of my colleagues. Some are actually here today, about the diagnosis of CRAO using an emergency department using POCUS in a case series. And so this was occurring at Corewell Health, that formerly was called Spectrum Health, which is a health system in mid-Michigan. It's one of the top 10 now biggest health systems in the country. I believe it has about 20 different health institutions now after the recent merger. Big thank you to Dr. Mike Flannigan, as well as Mariah Barnes, 2 ultrasound fellowship trained emergency physicians out of the group in Grand Rapids, as well as Drew Orwig. Drew is an emergency physician as well as specializes in hyperbaric oxygen therapy. Dr. Jeff Jones is one of our research directors, and Kendall Stevens is a resident physician who was formerly a medical student who worked with us on this project. And I actually think she's in the audience today, so hope residency is going well, Kendall. And so our goals and objectives, right? We're an academic institution, so we're going to talk about goals and objectives. So we're going to be exposing to a case study of patients who went through POCUS ultrasound for monocular painless vision loss. We're going to talk about some historical precedent of the retrobulbar spot sign and CRAO, as well as expose you to a few different scientific studies illustrating the role of hyperbaric oxygen therapy in CRAO, which is a pretty controversial topic, and looking at the literature and what's growing in that regard. And so let's start with a case. 65-year-old female, new onset monocular vision loss over the past 4 hours. Vital signs are as described, a little bit hypertensive, afebrile, not tachycardic, really not tachypnic, and oxygen saturation looked good. BGL was reassuring. Past medical history of hypertension, AFib, cardiomyopathy, hyperlipidemia, medications, not surprising. And she arrives in here in your emergency department today. And so I would love some engagement. So some of the fellows on the call, if you can unmute and give me some of the things you're thinking about in terms of your differential, I would greatly appreciate it. So please be brave, unmute. And what's our differential diagnosis here?
You're thinking about like CRAO, CRVO, and retinal detachment.
Okay, CRAO, CRVO, retinal detachment. Thank you, Connor. There are some other things here as well. Somebody else, please. What else is on our differential? So in the realm of retinal detachment, perhaps vitreous hemorrhage or vitreous detachment is also on our differential. Let's say in the course of the workup, NIHSS is 0. You do a CT head, unremarkable. The CTA is pending. It's a busy emergency department, but you just learned in either a residency or fellowship the role of ocular point-of-care ultrasound, and you take the ultrasound into the room, consent the patient for an ultrasound, and you perform an ultrasound. Let me just advance my screen. Here's a differential that we talked about. Amaurosis fugae was another one we would add, as well as posterior circulation stroke. But in the course of your ultrasound, you have a linear probe. This is the right eye. She has, remember, monocular painless vision loss. And you perform an ocular ultrasound. I would love one of our fellows on the call to describe what we're seeing here today. What are we seeing? Does anybody know what this is called?
Retrobulbar spot sign.
Retrobulbar spot sign, exactly. So as I'm going through using my linear probe, looking at my different portions of the eye, we have our anterior chamber, we have our optic disc. If I were to measure, there's no evidence of papilledema here, but I'm noticing what was called the retrobulbar spot sign, also called a Holland-Hurst plaque. This hyperlucency right just distal in the central retinal artery, all right, which comes from the ophthalmic artery, which is a branch from the internal carotid artery. So if I look at that, that shocked me in this case looking at that. I had never seen that before, but I knew that that was abnormal. I should not have seen that in the optic disc present there. And so that is, as we described, a pretty serious finding for CRAO, Central Retinal Artery Occlusion. This young lady, 65 years old, very active in her community, loves to play tennis, very much energetic, very much active. And this could potentially be a devastating injury to not only her quality of life, but also her long-term morbidity associated with it. So I gave a call right away to our ophthalmology team, in addition to our hyperbaric oxygen team. And before I discuss that, I want to take a step back and look at the retrobulbar spot sign. There is some literature to show that it can be used in the diagnosis and management of CRAO. But the one paper that really started to discuss this was from 1992, all the way down to an ophthalmologic society article written and published in that journal since 1864. But it talked about the retrobulbar circulation in patient and specifically central retinal artery occlusions and what that could be concerning of. So in this case study that we had described, my colleagues and I, we found multiple patients who had the same pathology, specifically the Holland-Hurst plaque or the retrobulbar spot sign. This is from 6 different patients, but all having a consistent hyperlucency noted just distal to the actual retina in the actual posterior chamber in the optic disc. And so this was 6 different patients we had in a case series. But as we take a step back and look at the anatomy, this is the board image for those of you who have taken your boards or who will take your boards on what is shown quite commonly, right, Sandy? Specifically with what is this, or they'll give you a second order question on this. But that's our cherry red macula, that's our CRAO if you had a fundoscopic examination at the bedside. But let's look at the blood supply here, right? So we have the optic nerve coming in, we have the ICA branching to the ophthalmic artery, and the ophthalmic artery right down here is going to be your central retinal artery, a branch off the ophthalmic, which is a branch off the ICA. But the other blood supply that you have here is the posterior ciliary arteries and this kind of ciliary complex here. So it's a pretty hypervascular area, and arguably and ironically has the most oxygen consumption of any tissue in the body, even more than the brain tissue or the heart tissue. think about the vasculature of what property that this is actually providing blood supply to. A very, very area that's rich in nature, but also an area that we have to make sure is hypervascular. So our study was 3 years. There were 7 affiliated hospitals, retrospective in nature. We used a Zonar L10 probe. It was QPath. We had our reviewed by ultrasound trained, specifically ultrasound fellowship trained, and practice pathway certified attending physicians. The mean age was 64. A little bit over half were female. The mean vision loss was 21 hours. I'm curious for those in the audience, our fellows say, why do you think that mean vision loss was 21 hours, perhaps longer than we would have appreciated if somebody had a facial droop or somebody had unilateral weakness consistent with other signs and symptoms of a stroke? Why do you think that the hour or the mean vision loss was a little bit longer? And I can't see the chat, so if you would unmute, that'd be great.
I can follow the chat as well as unmute if anybody does not want to speak or can't unmute but wants to put something in the chat.
Thank you, Sadie.
I have no idea what I'm talking about, so I'm going to throw a possible answer out there. So the oxygen consumption is super high, so recovery and refractory period is longer?
You can have a refractory period. Sometimes it's transient in nature due to the adequate blood supply from 2 different sources. But most often than not, people don't think of this as a stroke of the eye. We know it to be CREO as a stroke of the eye, but most often people say, I'm just having difficulty with my eye, it's blurry vision, right? When we teach people about stroke, the lay population, it's, are you having facial droop? Are you having any asymmetry in your strength? Are you having trouble speaking? Are you having aphasia? We're not teaching people, if you're having, unilateral eye blindness, that's symptoms of a stroke. So that's really a paradigm shift for people. So our population for CREO is much more likely to wait longer than we would have anticipated with normal stroke population. And what that does is we know that therapies that we would institute for CREO are less likely to be successful even 90 minutes after the start of somebody having monocular vision loss. So that's why a lot of these patients, A, don't get better, but B, we're looking for more treatment paradigms for them beyond just the simple ocular massage, and why hyperbaric oxygen was considered for this patient. So of our population, we had 9 different patients, very distinct, a lot of different comorbidities associated with it. A lot of our patients had CAD, atrial fibrillation, more likely to have thromboembolic disease or cardioembolic disease. But 78% of those had the retrobulbar spot sign. 67% underwent hyperbaric oxygen treatment. And of those who underwent hyperbaric oxygen treatment, roughly half of those improved with their symptoms. One of the limitations is a very small sample size, but I challenge you, if you look at the literature, most of these case series are very, very small, right? It's hard to kind of get a gathering and a swath of a lot of these. The retrobulbar spot sign was very sensitive, but not specific. You're looking at anywhere from about upwards of 70% sensitivity, but roughly about 40% specificity. So we're really good, not a large swath, but it's very non-specific for CREO in nature. Just want to move this one moment.
Nick, I noticed you had 2 or 3 patients who were several days out. Mm-hmm. And I'm curious, and then the rest of them were within hours. And I'm curious if there was any correlation. I realize this is a super small sample size between the length to the time to presentation and the presence of the spot.
It's a great question. We did not, do any specific measurements based on the depth of the hyperlucency as it relates to the longitudinal nature of how long people actually went without vision. That's a good follow-up for our team that we're going to make sure. I'm going to engage my research team to try to look back at that, because I think that's an excellent correlation that I haven't seen previously described. So thank you for that comment. I'm going to continue here. So let's look at hyperbaric oxygen treatment. So I placed the call to the ophthalmologist. I was a second-year resident physician. I was excited, and I proceeded to get a very respectful disagreement on the phone, I will say, from ophthalmology regarding the role of hyperbaric oxygen treatment for CREO. This is a debilitating, issue. This is a debilitating presentation, illness, and many of our patients, as we saw, were very much outside of the 90-minute window, if you will, for intervention. there was really no good treatment paradigm for it. They talked about intra-articular TPA. Sometimes ophthalmology would actually do a procedure to reduce the amount of intraocular pressure via specific procedures in the anterior chamber. But there's been some literature showing us from 2000, 2001, as well as down to 2021, that the case series of hyperbaric oxygen therapy is promising for this. So where I was at the Grand Rapids Spectrum Health, Dr. Orwig was a hyperbaric oxygen fellowship trained physician and actually would take these patients into the hyperbaric oxygen therapy chamber. And the pathophysiology behind why this treatment potentially works is, as I showed you the blood supply from the ciliary arteries as well as the ophthalmic artery, the thought process is, if you create some hyperbaric oxygen therapy, you can actually create some distal flow past the area of occlusion into these subsegmental arteries on the other side, preventing or perhaps enriching that area of oxygen-rich nutrients to try to reform and restart that vision. And it's predicted that patients who undergo hyperbaric oxygen therapy within the first hours of actual therapy actually have improvement of their symptoms. And as we mentioned, this was a very debilitating issue had we not intervened on, but finding a retrobulbar spot sign at the bedside for this series of patients and getting roughly 67% of our cohort into hyperbaric oxygen therapy, 50% improved, right? There's not a thrombectomy that's part of our treatment paradigm for this patient cohort. We're not giving tenecteplase or IV TPA for these patients. But the argument is this is a stroke of the eye, and the ability to establish a time-sensitive diagnosis with point of care ultrasound, specifically ocular ultrasound, really helped aid these patients in their pathway and advocating for their patients. So there was a question at the beginning of this short presentation about, I'm an EMS physician. I work for the fire department of New York. I work for a urban search and rescue task force. How did I get into ultrasound? It was about being curious. I'm not an ultrasound fellowship trained physician. I have much respect for my colleagues like you who are in that field. But I really want to challenge our fellows in the audience today. Read this paper. It will be the best 10 minutes that you probably had in a while regarding your wellness, regarding humanism in medicine. This was described to me by a cardiologist while I was in residency. Faith Fitzgerald, for those of you who don't know, internal medicine physician out of University of California, Davis. Wonderful article about the role of being curious in medical education and as learners. And I'm not going to ruin the ending to the story for you, but suffice to say, she was challenged by her resident physicians that she could not find anything interesting about a certain patient who was older, who was in San Francisco, who, let's just say, came over across the Atlantic Ocean via a specific modality. Again, I'm not trying to ruin it, but take the time to look at this article. It describes the role of being curious in medicine. I think the more we can maintain curiosity, the farther we get after fellowship, the better we can do. But overall, really enjoyed this case series about being curious and finding some opportunities. Had a great research team here, as you can see, and I'm happy to answer any questions you might have.
Awesome work. Thank you for all that. So if I have a great story for a CRAO and I do the ocular ultrasound and there are no findings, do you think that patient, if they don't have an a retinal detachment, vitreous detachment, spot sign, and symptoms of GCA or something like that, would you consider a lytic in that patient if it was within the 4.5-hour window?
Personally, I would not. That would be a conversation I would have not by myself. I would have that with ophthalmology as well as neurology. I think that's a decision made best by bringing in other consultants. Tenecteplase and TPA, it's not an indication to give that for monocular vision loss.
Mm-hmm.
You could make an argument that this is debilitating enough to consider it, but I have not appreciated adequate literature showing that this is a slam dunk indication to give lytics. Because as I described, it's pretty controversial in the ophthalmology space, hyperbaric oxygen therapy. I'll give you a perfect example. On some of these patients that I described and I saw, ophthalmology wasn't recommending hyperbaric oxygen treatment, but a hyperbarics was. So it created some professional disagreement, always professional, but I think more literature is needed showing the advantageous nature of a therapy that is really harmless. It's innocuous. It's not going to harm the patient further. The patient walked in with blindness of her eye. She's going to walk out with blindness of her eye unless we try a therapy that might help her. And so on a few of these occasions, as I mentioned, roughly 67% or 48%, our patients actually walked out with tangible improvement, objective improvement on the Snellen eye chart, being able to see further, being able to see with much more clarity.
Yeah, I work at a stroke center. So one of my stroke neurologists was asking me about this. Is like, if you do the eye ultrasound and you do see a spot sign, I'm not going to give lytics, was the decision algorithm for him. And we are a good, hour by flight versus 2 or 3 hours from the nearest hyperbaric center. So hyperbarics is really out of the question for us. So it'll be interesting to see what the data shows in the future. So
absolutely, thank you for your questions.
Hi, Nick. I just have a comment. I'm Lynn Rapolo. Thank you so much. It was really interesting, and I just loved hearing kind of how you work through that and seeing more than just one case. You did a case series, which was great. I had a kind of an interesting situation the other day when I had a patient with monocular vision loss that was painless, and CRAO was in our differential, and we were looking for that spot sign. We didn't see it. And I did something very unusual. I had actually ended up doing a fundoscopic exam, and I figured out the diagnosis because we couldn't see the lens, because, something else in the diagnosis was it a cataract? Mm-hmm. But the way he described it, it made us think of more of CRAO. And anyway, so I actually put color flow on the optic nerve because the central retinal artery kind of goes in the center. And so I was able to see flow, and then actually converted it to pulse wave Doppler just really quickly. And I didn't get a good waveform because I don't know if because the flow was so low, but I was actually able to see a little flow. And so I looked at my resident. I go, let me just do a fundoscopic exam because I couldn't see the lens very well. And lo and behold, he had all those findings. So I kind of felt stupid, but I was just wondering your thoughts on color flow. And anybody else?
It's interesting.
Coming in and also Doppler.
Part of our research we did, and I think it's a wonderful question. Part of our research that we didn't publish on this initial study was looking at specifically Doppler flow and color flow on that patient population before hyperbaric oxygen treatment and after hyperbaric oxygen treatment. So my hope is that could be part of the next steps as what we do on that cohort is publish that data. But I think it's something that's worth characterizing, and I would encourage any learner, any physician, if you have monocular unilateral atraumatic vision loss, A, point of care ocular ultrasound, absolutely, but B, checking Doppler and checking color flow before a therapy, I think would be essential.
Thank you.
We had a question in the chat about the time frame for hyperbarics in the setting of CRAO.
I think it's a great question, Rajesh. Unfortunately, there's lacking literature regarding, a centralized protocol. Some of this research comes out of Hennepin County, up in the University of Minnesota, in the Minneapolis area. However, our therapists here, our hyperbaric oxygen therapists, are taking patients 22, 24 hours later with that diagnosis of CRAO to hyperbaric. So some of the literature that I showed you from 2021 was talking about within the first 90 minutes, within the first 4 hours. However, there's not really a set protocol similar to like TPAs within 4.5 hours. There's no universally accepted standard at this point.
Yeah, interesting. It's so tough to find an adequate number of these cases. I think having a big health system is helpful, or this is something we'd have to do like multi-center, and depending on hyperbarics, because we're like you, we're like Dan, we have a it's a couple hours driving, probably 30 minutes by flight, maybe probably an hour by the time you get them on and get them off to a hyperbaric chamber. But I've actually I had a patient in AFib with this, and our neurologist said, we don't really want to do TPA. Maybe we could do half dose, maybe we could do heparin. They were like, trying to figure out what to do. We wound up heparinizing the patient, and they did regain some of their sight. So I don't know. That's interesting. And I'm curious. So were all of the people who were doing these scans over time, were they all looking for this spot? Or was this just something that was found on your review of the studies?
I wish I could say this was a very well thought out process, very scientific in nature. But as we all know on this call, my colleagues would tell me, Nick, the thing you presented, that retrobulbar spot sign, I saw that the other day. I said, where? And then we started to put these patients together, and I heard of another one. So it was much more organic in nature than retrospectively looking for that diagnosis. Many of your co-fellows, many of the residents at your institutions will tell you about a good case, and then you'll hear about another one, you'll do one yourself. And I think we need to do a better job in medicine and in academics, actually taking the time to log those numbers and log those specific MRNs so we can long-term follow them. But yes, that's how it started.
Cool.
And if
All
there's anyone interested in collaborating on a future CREO project, please, I would love that opportunity.
Cool. Any other quick questions? Because we need to transition to the next article. Okay.
Nice to meet you all. Thank you for the opportunity.
Thanks. And I know you have to run off to an EMS activity. So
thank you all.
Thanks, Nick. Appreciate your time.
all right. So I think I just shared my screen, right?
Yes, you did.
Yes. Okay. So this is our second article, and I wanted to